Hello and welcome back to CardioSource Video News. This is ground zero for breaking news, and we're here at the Georgia World Congress Center where there has been a lot of activity today, including live cases from the I2 Summit, as well as several exciting late-breaking clinical trials. To provide you full coverage and in-depth analysis, we have a panel with a lot of impressive credentials. First, on my immediate left, is Dr. Chris Cannon. Chris is the senior investigator of the TIMI study group at the Brigham and Women's Hospital. Next to Chris is Dr. Athena Pappas. Athena is the director of the echocardiography laboratory at the Rhode Island Hospital. And as I've said numerous times, last but not least is Dr. Tony DeMaria. Tony is professor of medicine at the University of California at San Diego, and as you're well aware, is editor-in-chief of the Journal of the American College of Cardiology. I'm glad to have all of you with me. Athena, I'm going to start with you. You know, a lot of exciting stuff today. We've learned some, I think, some new things. What trial do you think might impact practice the most?
I think one that really struck me was Race 2, which was sort of a follow-up to AFFIRM, looking at the rate versus rhythm control, but really looking at strict rate control versus more lenient rate control, because I think we really haven't had a guideline. We've wanted to push the rates down. And it was a non-inferiority trial, and indeed, it doesn't seem that there's a big difference. And the goal was, again, from the guidelines, 60-80 at rest versus 90-150 with exercise. So more events. So I think we can feel a little comfortable about relaxing, particularly on our older patients. We were nervous about that.
What, Tony, does that, I mean, what Athena was talking about, this trial, is that new news for you?
It is new news for me, and I think important news, because I think all of us have felt compelled to really keep that rate down, and multiple drugs and often side effects. So I think this is going to be better for us. It's going to be a lot better for the patients.
Absolutely. And while I've got you, what struck you today about that really was an impactful trial?
Well, impactful may be the wrong word, but one very controversial trial was a study that looked at the benefit of dual antiplatelet therapy for longer than a year after the implantation of a drug-eluting stent versus just aspirin alone, and in fact reported that there was no difference, and indeed a bit of a trend toward a worse outcome with the dual antiplatelet therapy. This very controversial, small study, underpowered, subgroup analysis was not possible.
Can you tell me anything good about outside of that?
Well,
because those are important things.
I will tell you some things that are good about it, at least I think. And one good thing is that many of our patients really represent hazards for bleeding, and we put them on multiple anticoagulants. And given these data, there's a little bit more justification for perhaps discontinuing therapy.
But what about we've had happen is some of the interventionalists have said, look, this is a high-risk lesion. This is a lesion that really ought to have a little bit longer. So maybe tailored therapy we shouldn't throw away yet.
And Chris, you
were
going to
say, that the strength here is it's a randomized study. We actually don't have any randomized data. We've relied on registry. So the Duke database looked and tried to adjust. It looked favorable, but it's observational, and we know the hazards there. It's a good caution, I think, to say, not indiscriminately say, oh, indefinitely, we know it's better long-term therapy, to just say pause. It's a modest study. For the primary endpoint, it's 20 versus 12 in the wrong direction. So very small numbers of patients, even though about 2,600 randomized patients. So this encourages participation in the large dual antiplatelet therapy trial, or DAPT. That's going to be 20,000 patients with 2 to 3 years follow-up. This was about a year median follow-up. So again, caution on assuming that, it must be better, that we need to go step by step.
You know, if I might just interject here, this is one of the difficulties, Randy, that we face as editors. What do you do when you get a study that's imperfect in an area where you have no data at all?
Right, absolutely.
And you have to decide, is a little bit of data, even though imperfect, better? And I think that's probably what they came down here.
That's a great point. Chris, the good comments there. Did you have something today that sort of struck you?
Well, I think we can talk about another antiplatelet therapy adding on cilostazol that you heard as well. That was a disappointment and did not appear to help. And so, again, we're finding that some of the things we would say, oh, it must be better to add on a triple antiplatelet therapy in that case did not appear to turn out as well.
Go ahead.
I just think one piece from that I took was there was a subgroup analysis that women actually did worse in that group. So, again, talking about using some subgroup analysis for looking at some of these trials.
Yeah. I sat in on that one, Randy, and I thought the most important point that came out of a negative trial was that all the patients who had substantial reduction in platelet reactivity were event-free. And I think, although it's provocative and unproven, the take-home message might be, boy, if you treat platelet reactivity measured by any technique, that may be the best way to judge antiplatelet therapy.
I'd say in JACC there have been a series of terrific papers, reemphasizing that, and the high residual platelet reactivity has now been seen across numerous settings with different tests as a real marker. And there are several trials now doing the randomized tailoring of therapy in that group. So that is coming soon, I think, reaffirmed that this is an important group to look at.
Other thoughts from today, other things that you heard or sat in on, Tony? I'll come back, Athena.
There was an interesting paper, again, devoted to stents, where they did away with a polymer, and they combined sirolimus and probucol, an older drug with some toxicity, but a fascinating approach in doing away with the polymer, which is presumably responsible for much of the inflammatory reaction. And it was a 2-year study, 18-month study, as opposed to 8-month study. Again, INPRESS and JACC, and what it demonstrated was that the benefit of this regimen that prolonged the elution of sirolimus was beneficial, and that the sirolimus, the cipher, it really did have the so-called catch-up phenomena where there's a reduction in lumen diameter over time.
Super. Athena, you were going to jump in on something.
Well, I was at today talking about both structural heart disease and some new advances in 3D echo, that we see two things emerging rapidly together, how 3D echoes taught us a lot about the anatomy and function and how that might be changing sort of the way we do the percutaneous valves.
Oh, I don't think there's any doubt. I'm glad to see you brought up an echo topic in this panel. Chris? No, but I think it's a good point. Chris?
Well, there was a lot of information on AFib, and so 2 studies looking at ablation. And again, randomized studies, not the definitive ones, but both looked very favorable for ablation being able to reduce symptomatic recurrent AFib. And so I think...
And the new ablation device, cryoablation, which presumably will reduce the potential for tissue injury and thrombus formation, look pretty good, so that there may be better technology to apply to AFib ablation.
So some really neat stuff, and I thank each of you for doing that. Great insight. And we're going to have a lot more that you're going to want to stay tuned for here on CardioSource Video News. We'll be back in just a moment.